Now we are already done with the history taking of the psychiatric patient, and we are now moving on to the mental state examination in such a patient. So the evaluation of the patient is basically based upon this mental state examination, which is abbreviated as MSE. The appearance and behaviors are noted down in detail whenever we are taking this mental state examination into account. So the speech, mode, and thought form is again very important. The speech has its own variations. It can be the normal variations from person to person. So basically, we have to distinguish the normal variations from the pathological variations in the speech of the person. And then obviously, we are going to comment upon the mood of that individual as well. Moving on, the thought form is again very important. How is the thought formed in his mind is going to depict upon in his speech. So if it is going to be a flight of thoughts, then it is going to be a pressurized speech. So that is basically how you're going to define how this thought form is in a particular patient. Then we'll be dealing with the thought content. And how do you basically distinguish between the thought form and the thought content of a particular patient? Then the delusions and the hallucinations will be dealt with. Delusions are basically the firm beliefs that are basically the false perceptions of the person, but they're quite firm in that particular individual. And then moving on, we'll be discussing the hallucinations and the different types of hallucinations that the person can have. It can vary from auditory, tactile, somatoform to the visual hallucinations, and all of these basically exist in the different psychiatric patients. So that is all that we'll be dealing with in this particular section. The areas of examination are the appearance, behavior, and engagement with the interviewer is again very important. The example signs are the impaired self-care, poor eye contact, the restlessness, anxiousness, which is withdrawn and inappropriate in a lot of individuals. Then the speech is focused on. It should be socially appropriate, and example is not too loud, vocal intonations, poverty of amount. It can be a slow speech. It can be a pressurized speech, as I was already talking about. The flight of thoughts. If you have a flight of thoughts, then the speech will be pressurized. But this pressurized speech is even noticed in the normal individuals when they're anxious. So the preservative speech is also to be looked for. Then the effect and mood of a particular person is again very important over here. The depressed or elated moods, they are to be looked for. The incongruous or blunted moods, they're again to be looked for. Then the suicidal ideation is also again very important. If there are any thoughts of suicide, they have to be commented upon, and the plans or of actions, they're also going to be noted down. Then the thought form. Thought form is basically the flight of ideas, the night's move thinking, in which the person is quite conscious. Then there are neologisms. Neologisms is basically the formation of new words. The echolalia. Echolalia is basically when a phrase is continuously repeated. It is known as echolalia in a certain kind of a person. Then thought content is again very important. The poverty of content, obsessional thoughts, overvalued ideas, delusions, thought alienations. So all of these things have to be looked in the thought content of that particular person. Then we move on to the perceptions, the distortion of size, color, of intensity. There can be any illusions or there can be any hallucinations, for example, auditory, tactile, or visual hallucinations. The other examples can be the unusual movements such as dyskinesias or some tickling movements in a lot of individuals. Moving on, the patient basically reveals about the mental health. The poor self-care is due to the depression, the schizophrenia, and the observations on behavior. They are going to be noted down by the psychiatrist, whosoever is taking the history. The depressed person usually moves slowly, and the poor eye contact is again a clue towards depression. And the manic patients have boundless energy. They make expressive gestures and they do not respect the social boundaries at all. The communication can be difficult based upon the patient's mental status. So the speech, the mode of conversation is again going to be noted down. The underlying thought process has to be commented upon. The slow speech basically indicates in depression or the frontal lobe disorders. and the hesitant speech due to the internal experiences due to hallucinations, the rapid speech in mania due to the pressure of speech. The automatic repetition of a phrase is known as echolalia. So, this phenomena in which the person repetitively makes a phrase is known as echolalia. The word, if it is constantly repeated, it is known as philalia, and if a syllable is constantly repeated, it is known as logoclonia. So, all of these symptoms have to be looked on in a particular patient. If the patient is reluctant to speech due to the paranoia, it has to be noted down. Then the mood of the particular patient is noted down by the psychiatrist. If it is a subjective or objective mood, the depressed or the elevated moods are noted down and they're linked with the mood disorders. The abnormal moods in dementia or schizophrenia are quite common. So if you have the abnormal moods, if it is highly elevated or if it's highly depressed, then the person may be suffering from dementia or schizophrenia. The lability of mood can be a sign of rare variant of bipolar disorders. The range of moods can vary from low, that is basically depressed, to high, that is elevated or elated, to normal, that is basically euthymic, and the rapidly changing mood is basically known as a labile mood. And then smiling when discussing the death of a loved one is basically an incongruous mood. Basically, when you're describing the death of a loved one, you should be sad. So if he's smiling or if he's happy while describing the death of the loved one, then this is basically an incongruent mood. Thought form has to be distinguished from the thought content. The loosening of associations is very important when we are commenting of the thought form. The abnormalities of the thought form are the diagnostic relevance, the associated with the flight of ideas. Punning is more typical of mania. Punning is basically the rapid speech that is usually observed in mania. The examples are the night's move thinking. Thought content, there are a lot of disorders of the thought content. It can be the preoccupations, not necessarily pathological. Obsessional thoughts, recurrent persistent thoughts, images or impulses, they go through the mind of that person quite frequently, and it can lead to anxiety of that person. They're reduced by the compulsive behaviors, and in case of obsessive compulsive disorder and schizophrenia and in depression, all these obsessional thoughts are quite commonly seen. Now, when we talk about the overvalued ideas, it can be the thoughts that the patient firmly believes in, and then there are delusions. That is basically pathological in a lot of cases. The primary delusions, they basically include, they arise de novo. They're difficult to be certain of, and its subtypes basically includes the delusional perceptions, the sudden delusions, and the delusional moods. So it can be a disorder of the perceptions of the mood, or it can be the sudden delusions that the person can develop. And then they arise from, if there are secondary delusions, they arise from the other pathological experiences. For example, if he has a hallucination, to basically explain that hallucination, he has developed that delusion. So basically, it is known as the secondary delusion in that case. Then we have the persecutory delusion, that someone is planning against him, planning a conspiracy against that particular person. The thought alienation is very common in such cases. It takes form of the thought insertion and thought withdrawal as well. Thought broadcasting, that is thoughts passively broadcasted from an outer source, is another phenomena. Somatic passivity phenomena is quite commonly seen in such type of delusions, and delusions of physical control. They believe that the external agency is manipulating their mind, and they are likely to be schizophrenic. Then we have the nihilistic delusions, delusions of worthlessness, guilt, or poverty, delusions where belief is centered on loss, and then the delusions of grandiosity, they're again very common. The patient has over-exaggerated absolute beliefs, and self-worth or abilities are overvalued in such a patient, and the patient is usually manic or schizophrenic in such delusions. The causes of such perceptions can be organic or substance abuse, and the abnormalities of perceptions, distortion of the real perceptions is quite common. False perception in the presence of stimuli, that's known as basically illusions. And then we have hallucinations. Then the disorders of perceptions, they basically include disorders of size, which is also known as micropsia, and the disorders of colors, they're again very common disorders of perception. Illusions can be of health or illness, and they're of little diagnostic values, most common when consciousness is altered, for example, in cases of delirium, and when sensory input is reduced, for example, in dark. When the individual is distracted, in such cases, the illusions are quite common in such individuals. Then we have true hallucinations, the quality of normal perception, and they arise in the absence of stimuli. Most common hallucinations are the auditory hallucinations, and there are basically 6 classes of true hallucinations that include the auditory hallucinations, followed by the visual hallucinations, somatic or touch hallucinations. Then we have the olfactory hallucinations, in which the person basically tells you that he basically experiences a certain smell. Gustatory, that is taste hallucinations, and then we have the deeper body hallucinations that are usually of the sexual type. Then the patient shows dyskinesias, choreoathetosis, rocking, pouting, etc., and related to the antipsychotic medications. So all of these dyskinesias and choreoathetosis, they can be a part of a medication that the person is on a long-term basis. Stereotypes include that they are quite repetitive, non-goal directed movements, and mainly they are a part of a schizophrenic patient. So in this section, basically, we dealt with how a mental state examination is carried out in a psychiatric patient. So that is the end of this section. Thank you for watching sqadia.com.